Hi friends, in this topic of general examination, today I will talk about respiration. In respiration, we will be discussing about how to calculate respiratory rate, what is the type of respiration and various different patterns of respiration seen in the patients. First is the disclaimer. Caring Docs YouTube channel does not provide medical advice. Information available on this channel does not offer diagnosis or advice regarding the treatment. Information provided by this channel is for educational purpose only and it should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of medical expert for diagnosis, prevention and treatment of medical illnesses. There is no endorsement for any brand or a company. First is the respiratory rate. It is counted by placing the examiner's palm over the patient's abdomen and noting the rise and fall of the abdomen. Simultaneously, we have to divert the patient's attention by measuring the patient's pulse with our other hand. Normal pulse to respiratory rate ratio is 4:1 and normal respiratory rate is 16 to 20. When the respiratory rate is more than 20, we call it as a tachypnea, and when it is less than 10, we call it as a bradypnea. The physiological causes of tachypnea are in patients with person with anxiety and person doing exertion, and pathological causes are emphysema pneumothorax acute respiratory distress because of infections, pleurisy pulmonary embolism, metabolic acidosis, cardiac insufficiency, anemia hyperthyroidism, weakness of respiratory muscle, obesity, restricted chest wall diseases. And causes of Bradypnea are CNS-depressant drugs like opiates, benzodiazepine, barbiturates, alcohol, uremia, increased intracranial pressure, hypothermia, hypothyroidism. Coming to the muscles of respiration, the chief inspiratory muscle is external intercostal muscle and diaphragm, and whereas the expiration is predominantly a passive process, the accessory muscle used in inspiration are serratus anterior, sternocleidomastoid, scalene anterior, pectoralis, and trapezius. And the accessory muscles which are used in forceful expiration are internal intercostalis, internal intercostals, abdominal muscle, quadratus lumborum, and latissimus dorsi. Usually, two types of respirations are seen. First is the thoraco-abdominal or abdominothoracic. In thoraco-abdominal, uh, we see the movements of predominant movements are of that of thorax, and abdominal movements are less prominent. It is seen in females, and abdominothoracic respiration it is due to well-developed abdominal muscle, and it is seen in males. How do we check? We have to keep both hands flat, one on the chest and the other on the abdomen, and we have to watch for the movement of the hand. In abdominothoracic, the movement of the hand over the abdomen are more prominent, and in thoraco-abdominal, the movement of hand over thorax are more prominent. So abdominothoracic is preferably seen in males due to well-developed abdominal muscle, and thoraco-abdominal it is well formed. It is seen in females. It is because of well-formed internal intercostal muscles. Various variants of respiration are purely thoracic and purely abdominal. In purely thoracic, the abdominal movements during the respiration is absent, and in purely abdominal, the thoracic movement during the respiration is absent. Purely thoracic respiration is seen in peritonitis, pregnancy, ascites, or ovarian cyst, and purely abdominal, it is seen in pleuritic chest pain, defective chest wall, respiratory muscle weakness because of neuromuscular junction or muscular abnormalities. The various abnormal patterns of breathings are may be regular or irregular. Among the regular causes are chain stroke respiration and small respiration. Irregular causes are biot breathing, ataxic breathing, and apneustic breathing pattern. Among the regular abnormal pattern of breathing, first is the chain stroke respiration. Here we see the periods of apnea alternating with hyperapnea. It is commonly seen in left ventricular failure, which is the most common cause, and there is and also in patients with raised intracranial pressure, meningitis, brain lesions. Cosmal respiration is rapid deep breathing, and it is seen in metabolic acidosis because of diabetic ketoacidosis and renal failure. Irregular respiration pattern is seen in Biot breathing. Biot breathing is an uncommon variant of giant stroke respiration. Here we see periods of apnea alternating irregularly with a series of breaths of equal depths that terminate abruptly, and it is seen in meningitis. Ataxic irregular breathing pattern is seen in brainstem disorder, and apneustic pattern of breathing is seen in pontine lesions. So these are different types of breathing pattern. The normal is the eupnea, that is normal breathing rate and pattern. Tachypnea is increased respiratory rate, and it is seen in fever, anxiety, exercise, shock. Bradypnea is decreased respiratory rate when it is less than 10, seen in sleep, drugs, metabolic disorders, head injury, stroke. Apnea is absence of breathing, is seen in dead patient, head injury or stroke. Hyperapnea is normal rate but deep inspiration, seen in patients with emotional stress. Diabetic ketoacidosis. Giant stroke pattern of breathing is seen in increased intracranial pressure, brainstem injury. Here we see gradual increase and decrease in respiration with periods of apnea. Biot's respiration is rapid and deep inspiration, respiration, that is gasps with short pauses between the sets. It is seen in spinal meningitis, many CNS causes, and head injury. Small respiration is tachypnea and hyperapnea. It is seen in renal failure, metabolic acidosis, and diabetic ketoacidosis. Apneustic is a prolonged inspiratory phase with shortened expiratory pauses. Expiratory phase. It is seen in lesions in the brainstem. Pursed lip breathing, it is seen in chronic obstructive pulmonary diseases. It is because of mechanism of autopositive and expiratory pressure, that is PEEP. The purpose of this breathing is to slow down the airflow during exhalation to build up back pressure in the airway to avoid a sudden drop in intrapulmonary pressure resulting in the alveolar and airway collapse. In upper airway obstruction, we usually find prolonged inspiration, and patients with lower airway obstruction have prolonged expiration. Sorry, there is a correction for Z. It is L, lower as airway obstruction. In lower airway obstruction, we usually get prolonged expiration. Jonathan Swift has said, "The best doctor in the world are best doctor in the world are Doctor Diet, Doctor Quiet, and Doctor Merryman." With this, I conclude with today's topic. Thank you. Keep learning.